You are live, Madam Chair.
Okay, welcome back, folks. This is House Corrections and Institutions. It is Wednesday, April 9th, and we are shifting gears and we're going back talking to corrections. And we have some folks here from the Department of Corrections. It's going to give us a real background information in terms of how the beds and the facilities are used, what their purposes are. And that feeds into the term bed counts, and it's really important when we say the term bed counts, what is really behind those numbers and how the beds are used. So we have with us Jordan, I'm not going to even try to pronounce your last name, Classification Director from DOC, so if you could identify yourself. And we also have Josh Rutherford. Rutherford, thank you for being here.
Just as that.
This is backup. I'm not gonna be too hard on them.
Okay.
So welcome, if you could just identify yourself.
Thank you, Madam Chair. Good morning, everybody. I'm Jordan Pasha, Director of Classification for the Vermont Department of Corrections. As Chair said, I'm here this morning to talk about bed counts and bed utilization. You all saw this slide back in January when Josh presented, but just to kind of refresh the memories, these are the different ways that the department utilizes the beds that are available to us. So medical needs, mental health needs, risk intervention services, whether that be risk reduction services or VTIPSA, sex offender programming, honor dorms, restrictive housing and close custody, protective custody, the work camp, and admissions. And we'll kind of look at each facility specifically. I did include how many of our available beds are being used, and that's accurate as of 6:30 this morning. So as we break into the specific facilities, we'll talk about those numbers.
So let me just interrupt here. So for these categories, except for the work camp, are they in each of our facilities?
No. So risk intervention services is not in every facility. Honor dorms are not in every facility. And then each facility is able to address medical and mental health needs, but Southern State Correctional Facility has the units dedicated to that. Northwest State in St. Albans has a smaller unit that can be utilized for that purpose. And I'll talk more about that when we get to that.
I think that's important for committee members to realize that not all facilities have all of these beds.
Right.
And some facilities have more of some beds than others.
Correct.
And I assume you're going to more deeply define risk intervention services.
As best as I can. That's not my area of focus.
I ask before you had an opportunity.
Sure. Yeah. And as we get to the facilities, I'll talk about which facility offers which program.
I just don't know what it is. That's what okay.
In the restrictive housing closed custody, in other states, that would be termed segregation.
Correct.
You technically don't have
Close custody.
Not close custody, right? But
Segregation.
restrictive housing would be.
restricted. Okay.
So real quick, just going to kind of talk about the intake process. I did not include the facilities intake bed availability in my presentation because it varies so much. But when somebody comes into a correctional facility after we verify that they're legally allowed to be there, we reviewed their paperwork, they're going to go through the booking process. And for that duration, they'll be held in the admissions control portion of the facility. All of the
Booking.
which is called booking, yes. All of the facilities in the state have a booking area. So that is one thing that's consistent across all facilities.
What's the average number of beds? Is it 2 beds? Is it 5 beds?
It varies greatly by facility. Chittenden has a large booking area. They're able to hold a lot more than say Northwest is in their smaller booking area. So it's tough to stick a number on that, Madam Chair. So while held in booking through medical screening, they're going to have a suicide risk screening. We call that the Columbia Suicide Severity Rating Scale. They're going to do their PREA screening. If they're pre-arraigned, so they have not gone in front of a judge yet, they'll probably be held in booking for the entire time that they're there until they are arraigned, which is usually the next business day.
What about a weekend? Would they be held for the weekend in a booking area?
Most of the time, yes. If booking starts to fill up, we can move pre-arraigned into the restrictive housing units. Facilities try very hard not to do that, especially if somebody is a pre-arraigned misdemeanor, because there's different search protocols for misdemeanors versus felonies. They'll receive a mental health screening while they're in booking. If they're there long enough, they may have their caseworker orientation. They'll have their classification done. which assigns their security level and dictates where they would be housed within general population.
So would that be after they were arraigned?
Yes, ma'am.
That's really important for people to remember. So pre-arraignment, they would be held in booking until they go to an arraignment. If after the arraignment, the court sends them back to the correctional facility, then they would have the mental health evaluation as well as caseworker orientation and classification.
Correct.
Connor?
Yeah, could you talk a bit about the process of determining whether someone is appropriate or not for like a more general population setting? Like, for example, like if someone was former law enforcement, might make them like vulnerable, right? Or depending on the case they committed.
Yeah,
How does that work?
absolutely.
That goes into the unit assignment, right?
Correct. So we do an assessment called the CVS, the Conviction Violation Summary. So what that looks at is somebody's charges. If they have history with us, it looks at that history. It looks at their disciplinary history. It looks at kind of the media attention that their charge may or may not have received. And then it's a point system. So if their points are high enough, they become close custody, and then they go to a close custody unit. If they are not close custody, if they're minimum or medium, then they'll go to general population.
That's interesting. So it's a very scientific point system, you know, not just, that was more subjective.
No, it's a point system and it's standardized. But there are times, like you mentioned, where, you know, somebody's charge might rate them very high on the CVS, but they are a public figure or they're a law enforcement officer. In those cases, we might place them in protective custody, and we'll talk a little bit more about protective custody as we move along.
Great, thanks.
Of course.
Other questions before we move on from this?
I guess for the PREA screening, I assume that looks at the whole sort of spectrum. You're looking both for likely victim and likely perpetrators. You're looking
Correct. So they'd be identified as a potential victim, a potential predator, neither or both.
So could you explain what PREA is? Because I'm
Yes.
sure some members aren't aware.
Sure. So PREA is the Prison Rape Elimination Act. It was an act designed to cut down on sexual assault, sexual harassment within a confinement setting.
And that's more federal.
Correct. It is a federal mandate.
We have to abide by that.
We are audited to federal PREA standards every 3 years. Each facility has to pass, and the governor ultimately certifies states in compliance with those guidelines.
And
Kevin?
I don't mean to be negative. How often are you wrong in that screening? In other words, they're classified and then you find out we didn't get it right. They need to be in a different, is it very often or
I'm not sure.
don't know?
Josh, any ideas?
I should have said how effective is. the
Well,
screening.
I'd say in general, the system is fairly effective.
Good.
Our close custody is pretty good at identifying folks who are going to be violent. On the other hand, when someone comes in the door, we very often have limited information. If this is their fifth incarceration, we get a pretty good idea.
Right.
If this is their first incarceration, we might not. And sometimes folks who have committed very violent crimes are well behaved in institutions and don't cause problems. And sometimes folks who have committed relatively minor crimes can be very dangerous in facilities. You know, we don't know until we know.
Gotcha.
We make that assessment and then it's made to be adjusted over time.
Yep.
As the individual's behavior provides us more information.
Yep.
I think this is pretty key with what Josh just said, and I really want the committee to think about this. Think about it seriously. Because there's a lot of public perception and interpretation. And Josh just said, someone could come in with the most heinous crime and conviction and be the most well-behaved incarcerated person. And the public perception is the more heinous the crime, the more violent the person is, and the worse they are in prison. The worse behavior. And sometimes it's the complete opposite. Other times it could be a very minor crime, very minor behavior, but they have a lot of violent behavior while they're incarcerated. So I'm going to jump a little bit, Josh, and
Your
Jordan.
committee member.
No, and correct me, but where they are housed in a facility, their unit assignment, and where they are housed is based on their behavior while they're incarcerated, not the crime they were convicted of.
Correct.
I think that's really important for members to understand because the public perceives the worse your crime, the higher your custody level. And that's not the way it works in corrections. So that's a real important distinction for folks to have.
And conversely, sometimes folks assume that because somebody is well behaved, well, they're incarcerated, that means that they're a low risk community. That's simply not always the case. Sometimes it is. And it's certainly an indicator we look at, but that's not a good that I can say this person's doing well. That means I know they will do well in the community.
So now we're going to move into the more facility specific information. As we get into these slides, you're going to see two numbers separated by a dash. The first number is what the bed counts are this morning. The second number is kind of what the maximum count is overall. So looking at Chittenden Regional Correctional Facility, which is our female facility located in South Burlington, they have a total of 174 beds, and as of this morning, 133 of those are occupied. 96 of those beds are general population, and 94 of our general population beds at CRCF are occupied. They do have one honors dorm, which is a unsupervised unit. The women that live in that unit abide by rules that the facility has set up, but they're largely independent. They control their own movement. They get themselves to and from work, to and from their classes, to and from their programs. They do their own laundry, and they've kind of established their own set of community rules within that unit. 22 beds in there, and 14 of those are occupied. Chittenden does have a mental health specialty unit, 12 beds in there, 7 are occupied. Does have a segregation unit, 15 beds, 4 of them are occupied. Chittenden also has Foxtrot, which is kind of like a hodgepodge unit, a little bit of a catch-all. It can house close custody. They use it for behavior management for somebody who is just having a hard time in general population. They need a break kind of from the stimuli that comes with general population. They may be placed in Foxtrot to de-escalate a little bit and get themselves to a place where they're ready to re-engage with general population. Or they may be held in Foxtrot awaiting placement within general population because they just came in. So 14 of those 24 beds are occupied. Chittenden does have a 5-bed infirmary, which is currently empty. Yes, sir.
Where would federal or ICE detainees be housed?
ICE detainees are held in House 1, which is a general population unit. Superintendent Messier has dedicated 2 cells in House 1 to ICE detainees if needed. And federal may be throughout the facility in the general population unit.
And I had a question also, when you said the women get themselves to work in classes, that's within the facility or without?
Within the facility, yeah.
Of those 2 beds for ICE, how often are they occupied?
Well, it's 2 cells, so it would be 8 beds.
8 beds.
Yes.
2 cells. 4 beds to a cell. Is that in the booking area? Is that general?
That's general population.
General, and would you put them together, the ICE folks?
Yes.
Put together?
Yeah, they're normally held together unless we're made aware of some separation need, which is really rare from ICE.
So of those 8 beds, how many are usually occupied?
I believe it was 5 this morning, which is about average, a little higher than average. We're usually around anywhere between 3 and 5.
And who supervises them? Is it our correctional officers?
Yes.
And how long are they housed there?
I would put the average somewhere around 72 hours. That's climbing based off what we've seen in the past. But on average, around 72 hours.
And it's climbing, is the folks still coming across the border or is it something else that's happening?
My understanding is folks coming across the border.
And they're being held longer?
We have seen a slight increase in, and I think it's been in the press as well, in individuals who are picked up within the country and brought, not a lot, but it used to be only folks coming across the border really. And we did have, I think we had that scientist from Harvard that was in the news recently. It's a little unusual for us to have somebody who's caught inside the country and brought there.
So for a situation like that, who provides the security? The ICE folks that come into the facility for the security, or is that dependent on our correctional officers?
It's us. It's us. They're admitted to our custody temporarily.
And is that becoming problematic for correctional officers at all? Because there's no history there with us? Or putting more pressure on the staff?
I think the challenge is around language barriers. I think that's probably the most significant challenge. Not so much for folks who would be picked up in the country, but folks coming across the border. Very often there's language barriers, and it's not exclusively Spanish. And so that does create a barrier. We've got a process to address it, and translation services, but certainly it's more of a challenge than you have somebody who speaks English. You asked my question.
Brian?
I think this is kind of more of the same, but I'm curious about the pressure that puts on the COs. Is it just a few more bodies or are they watched differently? Does it change the routine? I mean, the language is obviously an issue, but.
Yeah, no, other than that, they're subject to the normal rules in our custody. And I don't think it's a significant disruption other than the language issue. It's more people. It's a couple more people.
And I've actually seen a call go out from an instructor at UVM looking for volunteers in the languages departments. So I guess maybe it's come to that, but.
I
I
see.
think the commissioner said this before this committee or perhaps another, but something we have noticed, especially in the colder months, at Northwest in particular, is, folks who are apprehended crossing the border without explicit authorization, and just some folks who have maybe some outstanding medical needs, who maybe need clothing, don't have shoes, folks in just kind of dire states as they cross, our cold northern border. And so that's something that I think our staff are really good at providing that support to folks when they come into our custody, when they're brought in by Customs and Border Protection. But certainly does place a bit of stress on our healthcare system. We don't have medical records for these folks; we just have their name, and so this is something to consider.
All right.
And then I know we're on a bit of a tangent here, but I just want to be as complete as possible. What's the intake been recently with folks who have transmissible diseases? The impact that has on our general population and the impact all of this increase in whether it's translation services, clothing, healthcare, what does that have on the daily costs to house these folks?
I don't have that information. I don't know if Josh is able to speak to that.
I'm not aware of any issues that we've had with transmissible disease.
Tuberculosis,
No,
anything?
I mean, we screen for that. We do a PPD planting for that. But I'm not aware of any issues with that. In terms of cost, are reimbursed for the beds that are used. Whether or not that captures our cost entirely, I'm not positive.
And I think the healthcare costs are separately reimbursed as per the contract we have with them.
Is this one that we get reimbursed at a much lower rate, or is it?
I think the per diem is $180,
101,
$80.
80.
And that goes straight to the general fund, not to DOC.
It goes to the general fund, not to DOC.
Same with our US Marshal beds. That's the general fund, not us.
But that's a one lump sum. There's not a special reimbursement for medical.
No.
I think I think there actually is, looking at the MOU, explicitly reimbursement for medical costs separate from the per diem rate.
I think so. I think there's it's like a cost plus.
Very good.
And who gets that? Is that does DOC get
I think it
that?
would be a payment to WellPath for the provision.
To WellPath. So it goes to the general fund, and in theory, your budgets are paid for directly by the general fund. So in theory, it's supposed to come back to your budget, in theory.
But I think that's actually an important mechanism that creates a firewall, right, between our system and kind of profit seeking or revenue seeking motive. In that there's no financial incentive for the department to increase the number of folks who are housed to increase revenue directly with the department. So I think that's an important mechanism that's currently in place.
You're a step removed.
Yes, yeah, that's correct. I would note, I think this was also in Ethan's article the other day, but I think the estimated cost per diem is about $299 in state per person. And there's a bit of difficulty when it comes to estimating costs of what it costs to incarcerate someone in Vermont, because there's a lot of fixed costs. We talked about this in this committee, but that's kind of on average.
And I was surprised to hear, I think you said that general population, 1 room, 8 beds,
One room is 4 beds.
one room, 4 beds. Will there be more description of that as we go forward? I mean, there must be some rooms that are one bed, I assume, or
I believe Northwest State has a couple of rooms in I&J, which are the satellite buildings that are one bed, but the majority of them are going to be 2 or 4,
2 or 4.
Yeah.
Majority,
depending on the facility. Yeah.
even the health specialties.
So the infirmary beds are, it's kind of one big room.
It's like an emergency.
Okay.
Separate beds.
Got
Yeah,
it.
yeah, like
Okay,
an emergency room.
That's what I've tried to get.
The mental health specialty unit at Chittenden is 2 beds per room.
Okay, thank you.
You're welcome. So moving on to Marble Valley Regional Correctional Facility, which is located in Rutland. 128 total beds at that facility, and their head count this morning was 142. They have 115 general population beds and currently have 128 individuals in general population. They have 8 segregation beds with 10 individuals in segregation. A special housing unit, which again can kind of be one of those hodgepodge things. Marble Valley is our preferred site for housing of juvenile offenders. So if we had a juvenile offender with sight and sound order, they would be placed in the special housing unit at Marble Valley.
So we have 4 of them there now?
No, those are not juveniles. Those are just people that are in the specialty behavior unit for whatever reason, I'm not sure. But there are no juveniles currently with sight and sound separation ordered.
But if you did have a juvenile, it would be in the special house.
Correct. So that number, if we had a juvenile with sight and sound separation ordered by the court, that number would be one out of 4.
Mary and then James.
So paint a picture for us, especially for the freshmen. How do you deal with this, that your beds are over, you're over your count? How do you deal with that?
Sure. So we start looking at space at other of the state's correctional facilities. We do have a state transport team who is able to move individuals between facilities. So what I'm going to do right after I'm done here today is go build a transport for tomorrow to move some people out of Marble Valley.
And when they're there for even a short period of time, where are they held?
It would depend on where they're at kind of in the intake process. With general population being that full, they may be held in the restrictive housing unit pending placement. Marble Valley does have the ability to utilize sled beds. We try not to do that, as try to limit that as much as we can, but there are times where sled beds may be utilized.
Explain what a sled bed is.
A sled bed is kind of like a plastic boat with a mattress that would be placed on the floor.
So you'd have a bunk bed, but then you'd have a sled bed.
Correct.
And those are designed so an individual's 6 inches off the floor. Although for whatever reason, most folks prefer to sleep in them upside down. So it looks kind of like a sled or a boat. But they're actually designed to be used the other way. So folks are 6 inches off the floor. And Jordan, I just wanted to add, we do actually have one 18-year-old with sight and sound separation right now.
Oh,
Just checked on that. Wondering where he went, but no, he's still there.
I thought we did too.
Yeah, no, he's there.
Okay.
He's not, nobody else is in that piece with him in that part.
The sled bed is a 3rd bed, usually right in a 2-person
Yes.
cell.
Correct.
Yeah.
So for folks for juveniles who are housed, there's no other place to put them. We have 4 beds up in Middlesex at the renovated trailers. It used to be the mental health secure residential. We have 4 beds there. We're a couple beds down in Windham County. Is that
I don't
up and
know if they're
operating?
Using those or not. I know there's a couple in Red Clover, but they won't take 18-year-olds.
And Red Clover is where?
Middlesex.
Middlesex.
Yeah.
Oh, okay, okay. So they won't take 18-year-olds,
They
they'll
won't-
take under
they won't-
18.
Right, and yes, not necessarily all under 18-year-old, but they can take under 18. At the moment, nobody can take 18-year-olds except for us, if they're ordered held.
So they would have been held at Woodside. And with the closing of Woodside, and we're looking to replace the facility that would house juveniles in the criminal justice system at the Virgins site. But that is all in negotiations between the state and Virgins. And what we're looking at there, if folks remember, is a design-build situation where a developer would build on state-owned property and then we lease the building. We'd lease the building. So in the interim, if they need to be in a secure facility, male or female, the males will go to Marble Valley. And they have, by law, have to be separated from the rest of the population, sight and sound separation. And the same for the females, they would be up in Chittenden.
If you want, I'm sure Jordan can speak more to how that sight and sound piece works and our obligations under law, if the committee's interested in diving that deeply on that.
I'm interested.
I mean, I guess I'm curious. I don't know if there are 30 people in these sled beds because that's about the amount that you're over. But have you seen a correlation? I'm sort of picturing Rep Hedrick actually in his day job works for student conduct at UVM, and the overcrowding when you do forced triples causes problems. I'm wondering if there's a correlation there with behavior or outcomes.
I saw that. So prior to this role, I was the chief of security at Chittenden Regional Correctional Facility.
Yeah.
And we definitely saw that kind of butting heads due to the closeness aspect at
Is
CRCF.
that when it was males?
No,
It was,
no, this was
it's
recently.
males, they were really over.
I was there then.
Yeah.
Yes, that was definitely a factor.
They were in the gym. They were all over the place.
So the answer to your question is
Yeah.
yes,
Yeah.
and that does happen.
And historically, prison overcrowding, and usually more dramatic than a couple of folks, but is connected with all sorts of bad outcomes.
Yeah.
It's harder to run a prison that is safe, secure, humane, clean, the more overcrowded you are. Now, we have a couple of folks, we manage that. It's not ideal, but we manage that. But there's been facilities in this country, and Chittenden back in the day, to the chair's point, that are 50% over capacity, 100% over capacity. And that really just makes it very difficult to be safe and humane, within that. That's something we've been avoiding the state for a number of decades now, but it's.
Moving on to Northeast Correctional Complex, which is located in St. Johnsbury. Total of 127 beds, and 123 of those were occupied as of this morning. In general population, they have 115 beds and 117 individuals in general population this morning. 8 segregation beds, 3 of them are occupied. 4 special housing beds, 3 of which are occupied. No infirmary beds, no programming beds, and St. Johnsbury also houses the work camp. 56 beds in the work camp, and as of this morning, 29 of them were occupied.
Isn't there another portion to that building too that also has another 50 beds?
There is. So
That's empty.
south unit is the work camp, and then north unit is what we would consider lack of housing. So people that are relatively low risk would be housed in north unit.
Do you have any in North Unit?
North unit is closed right now because we can't fill south unit. So it's feasible to have north unit closed for the moment.
So you're putting folks who are low risk and lack housing into the north, is it the North Unit?
The south unit,
The South Unit?
Yeah.
You're putting folks in there and mixing them with the work camp folks?
if they qualify, yeah.
Or would they are you saying if they qualify, is it qualifying for the work camp status or qualifying for low?
Qualifying for lower risk placement in south unit.
And would you ever put general population into the segregation area just because you got open beds there? As opposed to being on a sled bed? I mean, maybe
If general population was full,
you're
They may be
overloaded by
placed-
2 and you got beds in segregation. Do you ever use the segregation area for the overload?
we would, yeah.
Okay.
Yeah, they would be held there pending
Yeah.
availability in general population. Moving on to Northern State, which is in Newport. Our largest facility, 423 beds, 413 of them were occupied this morning. 402 general population beds with 394 individuals in general population. Segregation is full at NSCF, 8 out of 8. Close custody unit is full, 10 out of 10. 1 person in their 3-bed infirmary. NSCF does offer programming, but they don't have a special unit for those individuals. They're spread throughout general population. And the program they offer is risk reduction programming, which is for our violent offenders. Northwest State in St. Albans, 195 total beds with 193 of them occupied. 130 general population beds with 118 occupied this morning. This is our primary facility for the lodging of the male ICE detainers. Their segregation unit holds 20, 9 in there this morning. Close custody unit is full, 20 out of 20. They have no infirmary beds. And Northwest does house our VTIPSA, which is our sex offender programming. 25 beds in there with 27 individuals in that unit.
Why would there not be any infirmary beds up there? How do you deal with medical?
We have the infirmary at Northern and at Southern.
So you're transporting folk? How could St. Albans, which has 195 beds, not have an infirmary? I mean,
They
there's
used to have it, they used to have a small one. They had a small one and then they managed it a little more when the women were there.
And more
Because we needed it, but it doesn't make sense to staff a separate infirmary at Northwest. When we have an infirmary at both Northern and Southern. And we've maintained those other two spaces more than the one at Northwest.
So was the infirmary space reconverted into something?
I think it's, yeah, I think it's used for something else at the moment. Because we opened that new infirmary in Southern, well, I say new, it's 25 years old now.
So
But that was 10 beds and that really covered a lot and was more specially built to that population. I mean, the one in Northwest is, as most of the building is older.
Right.
So we have newer infirmaries at Northern and Southern.
So how do you deliver healthcare there? I mean, WellPath is operating out of St. Albans.
I mean, we deliver healthcare everywhere. You don't need.
Where are they,
you don't
right,
need
so where are they,
for that.
where are they based? Are they in the administrative offices?
No, medical at all of our facilities has an office. An infirmary involves housing for folks, like
Right.
medical housing. But medical at all of our sites has a suite of offices where they can, doctor's offices, nursing, so you can do sit call, and then
And
your
dental
administration
office.
of medical.
No beds.
No beds at Northwest.
Even Northern's is only 3 for a full 100 beds. Right?
Yep.
And the last in-state facility is Southern State Correctional Facility located in Springfield, 321 total beds there, 287 of them occupied. General population is full with 150 individuals in general population. Segregation houses 16. There were 12 in there this morning. Close custody houses 32 with 29 in there this morning. They do have an honors unit that holds up to 50. There are 29 in there this morning. Infirmary has 9 beds. The infirmary is full. They do have a mental health specialty unit with 36 beds. 32 of those are occupied. And then they also have a medical step-down unit with 28 beds, 6 of which are occupied.
Jordan, you just want to touch on the mental health, if those are 2 units.
Yes, good point. So the mental health specialty unit at Southern State Correctional Facility is split into 2 units, Alpha and Bravo. One is for kind of the more acute mental health stuff going on. And then I believe they're using Bravo as more of like a step down unit type deal. Similar,
Folks who are in better shape, yeah.
right? Similar to their medical step down unit.
Sorry to beat a dead horse, but if someone comes up with a sickness that's communicable, how do you contain them? If they're in general population, I mean, if.
So Southern has 2 beds that are in their infirmary that are actually negative pressure. Built specifically for communicable diseases. So that would be our preferable housing. Obviously in COVID, we sometimes had more than 2 people who were contagious. So we do have a process for managing that, but prisons are not ideal places for communicable diseases. It poses a challenge. We managed that during COVID. We certainly have some advantages over some states that have sort of your older style facilities with the bars. I know some of California's prisons had a really hard time because you had those open bar cells, but we don't have that. But yeah, if you get a lot of folks who are, and we have flu protocol. I mean, flu comes through facilities each year, and you treat folks. Folks might have to be restricted to an area. We might restrict a unit from moving around until a flu outbreak is contained.
Right.
So we talked some with folks who offered testimony earlier about doing HVAC in the facilities and the difficulty of swing space. I assume there are also sort of emergent things that happen. You don't have any swing space. Like, what do you do? Do you just move people into the gym, or?
We have 2 designated emergency spaces one in Northern, one in Southern that are prepared for emergency housing if we need it. And then after that, that would get us through to, okay, it's tomorrow. We've managed tonight. Now we can start figuring out what a long-term plan looks like, and that would depend on how much space was offline. It might require increased reliance on out-of-state beds. It might require keeping those open. We do have 2 places that we keep turnkey ready. So if we had an emergency, we have that housing available.
So our last kind of,
The other thing that happens down at Southern, that is your base for folks who are either going to Mississippi or they come back from Mississippi for transfer, right? So would they then just go into, you don't have booking beds there. How many booking beds do you have?
I covered that at the beginning of the presentation because it varies so much.
Oh, okay.
I didn't include that in the
So
number.
would they be held at booking or would they be put in general population or would they be put in SED?
For the out-of-state transfers.
Mm.
They would most likely be held in booking. I can't speak for Josh when he was in the role or Lonnie when she was in the role, but I try to move people either the day before the out-of-state trip or at the most, they're only there for the weekend.
And that's different now because we're usually moving 6 or 8 people at a time. There was a time when we were moving 30 folks in and out of that state. So it's consistent, and that made for a much different process than when you're trying to prepare 6 people for transport. But we haven't had to use out of state that way since before COVID.
So Springfield's the staging point. So just to keep that in mind too.
Correct. Just a little bit of info on our federal, on what we reserve for the federal beds, the U.S. Marshals detainers. Our contract allows for up to 60. The majority of them are going to be held at Northwest and St. Albans, Marble Valley in Rutland, or Southern State down in Springfield. The reason for that being the proximity to the federal courts.
So that is with the federal marshals,
Correct.
correct?
Yeah, separate from ICE.
Separate from ICE. The MOU, we have an MOU or a contract with ICE? We have an MOU.
MOU, yeah.
With ICE. And then we have a contract with federal marshals. And for the federal marshals, those beds are used for crimes that happen in Vermont that are federal crimes. And this is for folks who are arrested and detained for federal court.
There's a federal court in Burlington and one in Rutland. And federal crimes obviously often cross border. Generally, those are crimes that involve Vermont. Sometimes drug trafficking, weapons charges, things like that are federal offenses. Child pornography to be a federal offense, so things like that. But it usually are folks who have committed crimes in Vermont or crossing Vermont borders.
They're detainees.
They're detainees.
So you could hold them for a few months or a year or two before they go to court. And then once they have a conviction, they are sentenced and convicted, they go off to a federal prison. We don't house them once they're.
They generally go out to Raybrook, and then from Raybrook they'll disperse them where they need to go within the federal system.
And federal trials can take quite a long time to get to trial court, so it could be a couple of years.
And they would be held in general population beds usually, unless there's some.
It's also not uncommon for folks to have both federal and state charges. Folks who are committing those types of crimes sometimes have committed state crimes as well.
And what do we get reimbursed per day for those beds?
It's 130.
30, that's what I got it under.
And I will say that, the marshals are very thankful to the state of Vermont for accommodating this population. I think they have nearly 200 or so folks at any given time who are facing federal trial. And so they house, the remainder of folks that we can't house in Vermont in other facilities. So usually county facilities in Massachusetts, New York, New Hampshire.
The U.S. Marshals really have been good partners with us. We really, they work well with us and communicate well with us, and we've appreciated that.
And they don't have federal facilities, courts or whatever in Massachusetts? And I know that's a dumb question, but why do they bring them to Vermont and then the overflow is Massachusetts?
Yeah, so for example, my brother's a federal prosecutor in Burlington. So these would be folks that he would be prosecuting for drug crimes.
Crime happened in Vermont.
Yes, federal crimes that occurred in the state of Vermont. And then the federal prosecutors are bringing those charges in Vermont. And so these are oftentimes Vermonters facing federal crimes, or folks who are coming from out of state and committing federal crimes in the District of Vermont court.
Okay, thanks. Yeah, that's obvious. You know, that I think about.
So our last kind of housing option is our out-of-state housing, Tallahatchie County Correctional Facility located in Mississippi. We currently have 117 male individuals out of state, and we have the ability to send up to 300 per contract.
Right?
Has that contract ever been higher than 300? Yeah, that's what I thought.
I was gonna say we used to run somewhere in the realm of 600, 650 folks out of state at our peak.
Yep.
Prior to COVID, it was running about 250. And then since COVID, it's come down pretty dramatically and we've stayed sort of in this range for quite some time. This is the lowest utilization of out of state beds I've seen in 20 years plus.
Sometimes when we've done major renovations in a facility, we would really have to close a unit, and you're talking, particularly like in Newport or Springfield, those units are up to 50 beds. And you've got to move those folks. Sometimes you can absorb it within the other facilities, but usually most times you can't. And then you would ship 50 folks out of state.
And just at one point, we had about 2,400 folks incarcerated in the state. And this morning, what do we have, Jordan?
For out of state,
No, in state, what is our total?
1461.
So we're down almost 1,000 from the peak incarceration of the state. And that certainly has helped us reduce our reliance on state beds.
You have 14 and 61 folks who are incarcerated in state
No, total.
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 So minus 117 out of state,
And that information is on our website. It's updated every day.
right? And how many total beds do we have in Vermont in our facilities?
Did this math
16.
yesterday and I didn't write the number.
Around 1,600, is it
No, I don't think it's that many.
15?
Including the female facility, I thought I got around 1,200.
That's why I think somewhere in
It's
that
more
range.
than that. Isn't it more than that?
That's the question.
How many beds? You're just
And
thinking,
and of course, fewer than that are general population beds.
it's not as, I thought it was higher than 1,200 of our beds, total beds.
We have to remember, I did my math without factoring in booking beds.
Yeah, I mean, it's all beds.
Would be
Yeah, we
higher.
can cross check and get you a number on that.
Because we've done that look-see before.
We have.
And then you start, if you know what your total bed count, I'd like to have the total bed count that you had through your whole system, not the out of state, not including out of state, but all of our facilities. The total bed count. And then you can start siphoning off, well, X number infirmary, X number booking, X number, and then you really see what you're left with general population beds that you have flexibility with. Because that's the issue. There aren't enough general population beds that you have flexibility that you could bring folks back from out of state.
No, and I think we presented before, I think we run somewhere in the range of 130 to 135% over capacity.
So if you-
Some of which is definitely absorbed by that out-of-state population.
And forgive the hypothetical, but God forbid we had 500 we have to detain all of a sudden. Obviously, you can't just ship 500 people out of state if you're over. How does that work? Is there a time frame with this contract that says we've got to give you a week notice, a month notice, or?
Fortunately, I don't know that we've ever had a request to house 500 detainees all that quickly.
Right.
But if we start seeing an increase, then we start planning for what does that increase look like and where can we house that? As I mentioned, we do have those turnkey locations.
Yeah.
For emergency housing. We could look at expanding a contract if that was necessary.
Never experienced it.
Well, the movements have been more gradual, and allowed some opportunity for planning. And we try and run the system so that if there is a sudden gush or, a sudden increase, we have enough to absorb that. But yeah, if you suddenly had 100 more folks lodged tonight, I believe, Mr. Pasha and I and a number of other folks in the department would be very busy, trying to make that work.
So right now, we have over 500 detainees, right, in our system. It's been bumping up close to
See,
500,
those numbers.
502.
Yeah, I can,
502. But that includes,
62 are fed.
yeah, that includes the feds.
That's still a fairly high number of state detainees compared to where we were historically.
So you can't ship the detainees out of state.
Ah,
Detainees, because they're not sentenced.
yes,
They're
Clear.
not sentenced. So that's what's taking up a lot of our beds, is the detainee population. So what about the federal marshals? We have a contract for 60 and we're at 62. So is that taking away a bed from,
Two beds, I suppose.
and what about the MOU with ICE? Is that for the 8 beds?
There's no amount of beds, but DOC does have the ability to refuse individuals if our facilities don't have the capacity for it.
If we refused?
I
We,
believe-
we have
Yeah,
on certain occasions said,
yeah.
we can't take any more until you take some folks out, because we're full. That's certainly happened. And both the superintendents have the ability to make that call sort of in the moment, because they understand what they have for them available.
But there's no, in the MOU, they don't talk about the number.
No, there's no sort of hard cap on that.
So it really puts DNC in a tough position in a way to say, no, we can't take it,
The
right?
department is remarkably good at saying no sometimes. It's something we pride ourselves in. So I have great confidence in both superintendents to be able to say, no, I can't safely house more people, then you can't bring me more people. I don't have the beds.
And that's been honored.
But yes, it's been honored.
Not going to continue to be honored, do you think?
It is written explicitly into our MOU that we have that authority.
Other questions? So I mean, we can spend time and add up all the beds, but if you could send to Phil the total number of beds, and then we can work in subtracting out. Because a lot of your beds are specialty beds that you cannot house general population folks. You're not gonna house general population person in an infirmary bed. You're not gonna put them in a booking bed. You're not gonna put them in,
I mean,
custody.
right, that's it. You don't want somebody at a higher custody level. You don't want somebody in a restricted housing who doesn't need care. You don't want somebody living in a mental health bed who doesn't require that level of services. So anytime specialty beds have a great purpose in our system. They help us meet special needs. But anytime you create specialty beds, you create some limitations on what we can do to make sure we're using those beds appropriately. We've created those 2 honor dorms. Those have been a great addition to our system. They've worked well, but you can't just select folks out of a hat and put them in an honor dorms. That wouldn't be safe. So we have to be strategic and make good informed decisions on who goes in those beds. And it does, as the chair mentioned, impose some limitations on those beds.
So then at some point when it will be more next session, when we talk about the new women's facility in terms of how many reentry beds would be needed, how many specialty beds would be needed, and how many general population beds would be needed. Because you'd have your specialty beds and your reentry beds in one building. And then you'd have folks who qualify for the reentry case in a completely separate building. And that's where we're gonna see a lot of conversations happening next year. What size should that reentry building be? How many beds? And then the number of beds for the incarcerated setting, that's a medium or minimum security. And then people will get all hung up on bed counts. And I think it's really important to remember what beds are being used for. It's really important for that.
No, as I mentioned in response to your question, sir, when beds are oversubscribed, when facilities are over full, it gets harder to maintain a facility that operates the way you want to. And if the state designs a very nice women's facility that really meets our needs and meets the needs of the population, and then we're 50% of capacity because we underestimated the number of beds, it's a lot harder to maintain that the way that I think everybody in the room wants it to operate.
So that will be for next year, but it's really important to understand how our beds in our correctional facilities are used. Because there's a lot of interpretations out there that may not be accurate. There's a lot of perceptions out there, and perception takes on the form of reality sometimes. And I think it's really important for us as a committee to really understand the moving pieces and what beds are used for and why we have those beds.
Yep.
Questions? Anything before we finish up and move over to MOUD? Mode. Thank you.
Thank you very much.
Josh. Thank you, Jordan.
Our pleasure.
If you could just send to Phil the total number of beds we have in the system, excluding the out-of-state beds, not counting the out-of-state beds.
Okay.
Really help.
You get TV show.
Okay, folks, we are going to shift gears.
We'll break their hand up, right?
You need to take a personal break. So we're gonna shift gears to H32. You really take out your bill for folks. So we're really looking more on the medical piece on this today. And I would like folks to focus in on the language in the bill, please. And if you have suggestions on language changes or you support the language, it would be really important to hear folks. So if folks can pull out their bill, S32. We had some walkthrough with our legislative council. We did ask DOC to go back to their legal counsel. We'd like to have your legal counsel come in and testify. And then today we wanted to spend time in the medical world, and this committee is not up to speed and attuned to the medical world. So there is medical terminology used here. So we'd like to have some explanation of some of that. And some of it could be healthcare practitioner, what is medically necessary, how you define what's medically necessary. Healthcare practitioner, there is a definition. We want to make sure that definition is accurate. And just to help us through the medical piece that you folks work in, and then we try to dovetail that within corrections to make sure that there's cohesiveness in this and that it's appropriate language in your world and it's appropriate language in the DOC world. So I don't know, we have David Hurley, who's the executive director of the Vermont Board of Medical Practice, and Sheila Shelley Bonai, who is an RN and executive director of the Board of Nursing. So I'm not sure who's going to go first. I'm assuming the Board of Medical Practice, but I'm not sure. So I'll leave it up to you two who are on Zoom to figure it out.
Well, I don't know what your timeline is. I need to leave by about 11:45 at the very latest for a personal medical appointment. So
you go first. That works. And then David, if you could just identify yourself for the record too, as well.
Sure. For the record, I'm David Hurley. I'm the executive director of the Vermont Board of Medical Practice.
So have you had a chance to look through H32 at all?
Yeah, I just want to clarify. My understanding is what I looked at was a draft bill. It's was a version labeled 1.1. And so that's the one that I looked at.
That's the correct one. Yep.
And I wasn't sure exactly what you were going to be looking for. I did get some information that you had questions about scope of practice, and so I submitted some written testimony based on that information. But really, whatever questions you have is really important for me to be able to try and help you. But generally, what I saw in that draft bill, the first thing I would note is that I did have some concerns about the use of the term licensed to prescribe. There's several places where it talks about a provider being licensed to prescribe the medication in question, which is generally medication for substance use disorder or opioid use disorder, as I understand the intent of the bill. And
Well, it would be for both. It would be for both general medication. You know, it could be for heart or cholesterol, blood pressure, attention deficit, mental health issues. And then also there's another section of the bill that deals with the MOUD. So it would be in both situations.
okay, so but the specifically with well, this would apply generally, but also very much specifically to the prescribing of buprenorphine or other drugs for opioid use disorder, which are controlled substances and have a very specific use. The saying someone needs to be licensed to do it is not adequate, and there are additional requirements that need to be satisfied for someone to be able to prescribe properly, or as presented in the draft bill, to discontinue a medication. Would not be appropriate for someone to discontinue a medication that they could not prescribe in many situations. So they would have to have a DEA registration as well as being licensed to do it. They would also, it would have to be within the professional scope of practice. Now, with the Board of Medical Practice, we don't talk about scope of practice as often as they do at OPR, where many of their healthcare professions have a very defined and limited scope of practice. MDs have by licensure, they don't have a limited scope of practice. However, we do have some prescribing professions that are limited. For instance, podiatry. Podiatrists can prescribe controlled substances. But their practice is limited to conditions of the foot and lower leg. So a podiatrist cannot prescribe buprenorphine for substance use disorder. They can prescribe buprenorphine sometimes as an analgesic. Say, for instance, if the patient had a history of opioid use disorder and they needed an analgesic or a painkiller, sometimes buprenorphine is prescribed as an analgesic. And so they could prescribe buprenorphine if they had a DEA registration, but they could not prescribe for opioid use disorder. Another example would be a dentist. A dentist can prescribe, and they can prescribe controlled substances if they have a DEA registration. And it's probably the same. Someone from OPR might be in a better position to say for sure, but I believe that a dentist could prescribe buprenorphine as an analgesic, again, if the patient had a history of opioid use disorder. But it would be inappropriate for them. It's outside their scope of practice to treat opioid use disorder. So I, in my written comments to your committee, had mentioned that you might use language licensed, qualified, and authorized to prescribe the medication. And the authorized would get at both the idea that they need to have the DEA registration, and also like in the case of a physician assistant who practices subject to a practice agreement with what's known as a participating physician, it would have to be appropriate under the terms of their practice agreement with the physician who they work with. So those were the main thoughts I had about the language there.
So if I can interrupt and just for the Board of Medical Practice, and do you work with the Department of Corrections or have any insight into the delivery of healthcare services within the correctional facilities in that DOC contracts out with a private healthcare provider? Does the board work in licensing any of those folks, or is the board not connected at all?
The physicians and PAs who would work for the Department of Corrections or provide care to inmates in the custody of the Department of Corrections under contract would need to be licensed by the board. And there are occasions when the board receives complaints from inmates about their care. So we do have some familiarity with the boards, with the Department of Corrections healthcare delivery system.
So in looking at the language in the bill, both for providing medication for general health versus the MOUD piece, the language is that it would be a healthcare practitioner licensed to prescribe the medication. So if it's for general health care, which could be heart, cholesterol, attention deficit, whatever, it would have to be and this is how I'm interpreting it, but I don't know if it's correct. It would have to be a healthcare practitioner who is licensed to prescribe those types of medication. So in that situation, in the language, is it appropriate or not? I'm not talking about the MOUD. I'm talking about general healthcare and general prescriptions that you and I would have on a daily basis.
Well, if we're just talking about the whole range of prescriptions, I think one thing you need to keep in mind is that some people are on regular, health maintenance prescriptions that are not for the treatment of opioid use disorder, that are controlled substances, and that
like Adderall.
Right.
Like
they could be on stimulants for ADHD, like Adderall. They could be on pain medication that they need to get through everyday life. Or there are other medications that are controlled substances that people take regularly. So I would say that the concept of being licensed and qualified and authorized to prescribe would still make sense. And I understand that Sheila is going to talk about, the concept of scope of practice as well. And so I'm sure she'll have something to say about, making certain that it's clear that it needs to be within the individual's scope of practice to be able to do that.
So then I'm linking this to the definition of healthcare practitioner, which is on page 4, lines 7 through 10. And so we would be allowing a healthcare practitioner licensed to prescribe the medication. And the definition of a healthcare practitioner is a person who is licensed or certified by OPR, which is under the Secretary of State's office, or the Board of Medical Practice, to provide professional healthcare services to an individual during the course of that individual's medical care or treatment. Is that definition appropriate? Does the Board of Medical Practice know how many folks who are providing the healthcare within DOC? Is there a linkage there?
Well, I don't know how many people are working with the contractor to provide healthcare within DOC. I don't know exactly how many different professions are involved. It's probably quite a few. Many of them are going to be under OPR, not under the regulation of the Board of Medical Practice. I was a little bit confused. It seemed like perhaps the intent was to use a very, general term, healthcare practitioner, but then maybe you were trying to exclude like dentists or others who don't provide medical care. With that, as it continues talking about in the course of medical treatment, it seemed a little bit unclear. I think I was trying to understand why, some of the existing language lists the professions that prescribe for medical conditions. And those are physician, which could be an MD or a DO, an osteopathic physician. It also could be an APRN, and it also could be a PA. So I wasn't clear on why you were going away from using that list, which is pretty clear and easy for individuals to understand who you're talking about. And so it seems like that it might be more helpful to just when you're talking about prescribing or discontinuing medications, to just leave it at that would be my inclination.
What do you mean, leave it at that? Leave it with what current law is, where it states licensed physician, a PA, or an advanced practice registered nurse?
Right. And I guess what again, I'm not sure. And, clearly what you're trying to get at is a situation where someone's being admitted and you learn that they have a need for a regular prescription that they're on for a chronic condition or a course of treatment that they're undergoing. And you want to continue care, which is a good thing, to continuity of care. And so I guess what you're trying to do is to make sure that the direction to corrections in the law is that they're going to find a way to get a prescription for that inmate so that they can continue that care. And the situation, it makes me think of a situation that I've seen in the board's work where patients transferred, like say from a hospital to a skilled nursing facility, and the patient is going to need a prescription in the skilled nursing facility in order to continue their medications. They're not going to be administering or dispensing medications to the patients in the skilled nursing facility. If they don't have a prescription for it, they're not going to allow the patient to bring their own supply. So there needs to be a prescription. And normally what happens there is there's a discharge order from the hospital, and then the physician or other qualified prescriber who provides services for the patients in the skilled nursing facility signs an immediate short-term order for the prescriptions that are needed. And that's how I've seen it done. It seems like that's what you're looking to do in the correctional setting.
Well, we want to make sure, and we worked on this a number of years ago, the underlying law, we wanted to make sure that when a person's coming into an incarcerative setting, that there's the continuity of medication that they're currently on.
Mhm.
And that's what the law right now is there to address. We also have within the world of corrections, DOC contracts out with their own medical provider who is there for DOC. They're not a medical provider out in the community. They're there specifically for DOC. When a person is incarcerated, they basically lose those connections to those providers in the
Understood.
community. So we wanted to make sure that there was a continuity there.
Right, and I guess but there does need to be a prescription, and I noticed both in the existing law in 28 VSA 801E and is proposed to be added to 28 VSA 801B the phrase pending an evaluation by a healthcare professional. And I was confused if, it sounded like there may be an expectation that somehow or another medication could be dispensed or administered to a patient before there's been a prescription written, and there's going to need to be a prescription, whether we're talking about a controlled substance or a legend drug, meaning a substance that requires a prescription but is not a controlled substance. There is going to need to be a prescription. Now, the prescriber might not be required to see them personally and perform an exam to the extent that would be required for them, to meet the standard of care to initiate that prescription in the normal course of business. I mean, if they did have, and the other places in the statute talk about, getting confirmation about existing prescriptions from a PCP or the prescription monitoring system or other means. And, I think that a provider can legitimately prescribe a prescription with that kind of confirmed information. And in the situation where care is being transferred for the patient from one environment to the other, and even if there was just an evaluation, it would be, I don't know that it would be required, but if they had another healthcare professional who was not authorized to prescribe, but had done some kind of an initial evaluation of the patient when they were being admitted to the environment, then that would be helpful too in getting to a point where a prescriber could sign off on a prescription for that patient to continue that medication until they could have a more complete evaluation of the patient.
So current law reads, when a person is brought into a correctional facility, and if they are currently under the medical care of a licensed physician, a licensed PA, or a licensed advanced practice registered nurse, and who has taken medication at the time of admission pursuant to a valid prescription. And that valid prescription needs to be verified by the inmate's pharmacy of record. It's in current law, page 2, lines 15 through 21. That valid prescription has to be verified by the inmate's pharmacy of record, primary care provider, or other licensed care provider, or as verified by the Vermont Prescription Monitoring System. And that person shall be entitled to continue that medication because they already have been checked by the staff at DOC to make sure it's a valid prescription. If it's a valid prescription on the outside, DOC will continue that medication pending an evaluation internally. And quite often, in testimony that we received when we put this legislation together a number of years ago, quite often someone could come into an incarcerated facility and say, oh, yes, I have this medication, I have this prescription. And DOC will check back with a pharmacy or check back with a provider and say, well, we haven't prescribed that in 2 years.
Yep.
So they're not going to continue that medication. So that's why we put in the language, it has to be verified. So DOC has to verify from the inmate's pharmacy of record, primary care provider, that this is a valid prescription that the inmate is saying for that prescription. And then DOC can do a further evaluation. That's what the current law is stating.
Right, right. But I guess it just, I just was stating that, you know, when you read that, it doesn't address the idea that there still needs to be a prescription issued. And when it talks about pending an evaluation by a healthcare practitioner licensed to prescribe the medication, I think, you know, that raises a question in my mind of did they think in writing that there didn't need to be a prescription, or how is that drug going to be provided? There needs to be a prescription.
So that's what we need to ask within the DOC world, that question. Because this is all done while someone is in an incarcerated facility. And it's through our
Right.
contractor we have.
And again, I'm not aware if I'm pretty sure there's no, you know, exception in federal law, federal regulation that relates to drugs, making an exception to the requirement for there to be a valid prescription for drugs that require a prescription, because it's in a correctional setting. So there is going to need to be a prescription. And I think that it would be recognized as valid for a prescriber to issue a short-term prescription. And again, as I said, I know this happens regularly when someone's being transferred from a hospital to a skilled nursing facility, that the medical director or other staff medical person who's providing care for the patients in the skilled nursing facility will sign off on a prescription to continue the medications that patient being transferred in requires.
So we need to have more discussions with Department of Corrections and the medical piece in terms of how that transition occurs when a person is incarcerated, and then what really happens in the medical world, both within DOC and how they reach out to the inmate's primary care provider, if they have one. To really see what that transition is. Is the
Right.
committee following
Mhm.
for that? Because that's where we really need to start looking for that. And then maybe reach out to the outside medical world again, once we have a better understanding of what happens within DOC. Once a person comes in, goes through booking, what happens at that booking end with DOC and the medical provider outside. We need to have, the committee needs a better understanding of that.
You know, what's interesting too, so like, it seems like what we're hearing now is like, you don't need to be so prescriptive because these things can't happen, but based on the law, it's like, you kind of, it's already covered, like you're being redundant in some ways. And then we get Secretary of State's saying that it's not specific enough because these other people, but then, you know, so what we're kind of hearing is like an LNA can't give a prescription, but then, you know what I'm saying? They're looking at two ends of the same issue, coming at it from a very different I agree with what you're saying, David, but I'm just, but then you read this and it's the opposite.
But you're talking about MOUD.
Mhm.
I'm talking about general medication
Yeah.
right now. I'm not in MOUD. There's two separate
Mhm.
pieces of statute here.
Page 3 and page 7.
Yeah,
It-
2 to 3, 2 to 7 is your regular medication.
Mhm.
And then once you hit page 6, section 2 is MOUD.
Yeah, well, I'm only talking about prescription authority in general, but yeah.
Right, but the memos are
Yeah, I know.
MOUD. But
Yeah, it might be helpful if you just, if you think about it, though, that the requirements for a prescription are the requirements for a prescription. And but with controlled substances, there may be additional qualifications that the prescriber needs to have in order to be able to issue that prescription. But it's still the same idea. There needs to be a prescription.
Yeah.
And it's, DOC can't just have, an on-hand stock for short-term use for people who come in, whether it's blood pressure medication or controlled substances. They can't just have a stock that's going to get administered to new inmates. There needs to be a prescription, or they're not going to be able to provide the medication to that inmate.
So we'll look into that with DOC because I think the structure is a little different within DOC for that. I think they do have medication in stock. They do purchase it through a formulary. They do have the medication there in the infirmaries in stock. for
But they
that.
can't.
Well,
they
there still
can't
would,
give it without.
We do have.
Right, and
prescribed-
they have prescribers.
Yeah.
You have prescribers.
Yeah.
They have prescribing authority. And we're gonna look a little deeper into that for that.
Interesting.
More questions? So this is really our first, we had a walkthrough of the language of the bill with our legal counsel last week. And now we're taking testimony on specific parts. So we have flagged certain sections, certain language that you have raised some concerns about. We will then also hear from DOC in terms of how they address that. Other questions, thoughts from the committee? For David?
well, thank you for the chance to participate in discussion of this important issue.
Great, thank you. Thank you. So let's go to the Executive Director, the Board of Nursing. And
Good
is it
morning, Madam
Sheila,
Chair.
Shelley?
It's Sheila Boney.
Sheila
my
Boney.
mom.
So welcome. We are looking at the language within H32. I hope you've had a chance to look at some of the language and weigh in from the nursing aspect and also some of the language that we're using in definitions if they're appropriate.
Okay, thank you. Thank you for the opportunity to testify on H32. The comments today pertain to the draft dated on February 24th, 2025.
Yes.
So
Mhm.
OPR definitely supports policies that make healthcare available as widely as possible while maintaining the minimum standards of competence needed to protect the public. The draft appears to share that goal by specifying that only healthcare professionals may perform physical assessments and make MOUD prescribing decisions. We do have one concern, though. As currently drafted, a healthcare practitioner means, quote, an individual licensed or certified by the Office of Professional Regulation or the Board of Medical Practice to provide professional healthcare services to an individual during the course of that individual's medical care and treatment, end quote. Our thought is that that definition is too broad to protect incarcerated individuals, an extremely vulnerable patient population, from incompetent practice. So OPR licenses many healthcare practitioners who provide professional healthcare services, but who aren't authorized to perform activities specified in the bill. So for example, licensed nursing assistants and licensed practical nurses are not authorized. They may not perform independently the physical assessments that are mentioned in 28 VSA 801B. Other healthcare providers may assess patients only within the specialized area of practice. For example, dentists, optometrists, physical therapists. So OPR is recommending the following change to that definition.
Do you know what page you're on?
Page 4, well, which one?
For
There's
the
two
definition-
sections, so there, what OPR is suggesting is in the MOUD piece, not the general medication, is my understanding, correct?
That's correct, yeah.
So for the committee, the general medication, medical care is from page 1 to the top of page 6. You gotta have your bill in front of you. On page 6, section 2 is where it kicks over to MOUD. And the definition for MOUD in terms of, it's not in here, so
No, I think.
so it would be in the general medical piece, right?
Yeah.
That's what I was trying to get at.
So on page 4, lines 7 through 10, there's a definition of healthcare practitioner. That's what she's focused on, and that's what the memo from OPR is focused on. This definition is both for medical, general medical provider, general medical care of inmates, and it's also for the MOUD care of inmates. Okay. So there's a change, you're recommending a change in the definition, and would it be for both medical and MOUD?
It would.
Okay. And what are you recommending? And
So
I
we're
know we have the memo, but.
Yeah, so we're recommending the removal of the language that starts with to provide professional healthcare services to an individual during the course of that individual's medical care and treatment, and replace that with and acting within the individual's lawful scope of practice. So just so that it's clear for those licensees who are working in a DOC facility that if an activity is not within their scope of practice, they're not authorized to perform that activity, even if they're instructed to do so. So for example, for the assessments that are described in the bill, an LPN that would be working in a DOC facility could not perform that assessment independently. That's not within an LPN's scope of practice. So this just helps to clarify for the different levels of licensure that they have the things they're doing in support of this bill have to be within their scope of practice in order for them to engage in those activities.
Which sounds like similar advice concerning David's input that we need to possibly continue to use licensed and authorized adequate DEA registration and license specifically in that medical scope.
That's for opioid.
I understand. We're in MOUD right here, so.
So the definition would, what is being suggested, and doesn't mean we're gonna do it, committee, it's just being suggested to change the language in terms of what's currently before us. Take out on line 9, beginning the word to provide to the end of that sentence on line 10. And then to replace that with, so it would read, healthcare practitioner would be an individual licensed or certified by OPR or the Board of Medical Practice and acting within within the individual's
Mm-hmm.
lawful scope of practice. So we'll take that under consideration. We'll take more testimony on this. I know DOC wants to testify. Okay, whatever. We'll have folks come in and testify. Doesn't mean we're gonna do it. But that's part of our legislative process. And this change of definition would impact both general medical care as well as MOUD.
Mhm.
Okay. And the key is that it would clarify the different levels of licensure and also it'd be within their scope of practice. That's the reason for proposing a change in that language, correct?
That's correct, yeah.
Tell you, healthcare is out of our world. Other places you want to weigh in on the testimony, on the bill with testimony, Sheila?
No, I think that I agree with David's suggestion to have additional words in terms of authorization surrounding the whole prescription language. But other than that, there wasn't anything else that I came up with or General Counsel when we were reviewing the bill that we had concerns about.
So for that general, for the prescription piece, are you saying that by changing the definition of healthcare practitioner would take care of that?
If I may, I'm Deputy Secretary of State on the board. I oversee the Office of Professional Regulation. If I could just speak to the change in definition.
You'll have your chance.
Okay.
I just want to clarify what she was just saying about the prescription piece. By what you're proposing and changing the language, the definition of healthcare practitioner, does that cover the concern about who can write out the prescription?
I'm trying to think. I'm not sure that would satisfy what David's concern was. And I think that the way that the bill language reads is a healthcare practitioner licensed to prescribe. Isn't that the current language?
It's healthcare practitioner licensed to prescribe the medication.
Yeah.
So by changing the definition of healthcare practitioner clarifies the ability to who can prescribe that medication. It has to be within their scope of practice.
Right. Yeah, that language change might cover that.
Okay. Anything else you want to share, Sheila? Kelly? Sheila.
No, that
What
was all.
throws me, it's IE instead of EI.
It's a very unusual spelling and
Yeah.
it has caused a lot of confusion my whole life. But
Is there
no,
anything else you want to
didn't
weigh
have
in
any-
on?
No, that was all I was prepared to talk about today. Thank you.
Any questions from the committee? Okay. Thank you. Thank you, Sheila.
Thank you.
So we do have folks sitting around the room that we're not usually familiar with because this is a different world. And I know the Secretary of State's office is here. So maybe we've got two folks here and one person, three folks. We're not sure. Could you just identify yourself? And I say, we know you and Haley. Maybe you just identify yourselves for the other folks.
I'm Jennifer Cohen. I'm General Counsel for the Office of Professional Regulation.
I'm Lauren Hibbert. I'm the Deputy Secretary of State.
I'm Cecily. I'm just interning with Gail Zapp at Batson Brentford Consulting.
Great.
And I'm Michael Warren. I'm the interim director of the Office of Professional Regulation Program.
Great.
I'm Jordan Souter. I'm a policy advocate for the ACLU of the month.
So Lauren, why don't you come on up?
Thank you very much.
Maybe things could be clarified.
I'll do my best, Chair. For the record, Lauren Hibbert, Deputy Secretary of State, really a pleasure to be here with you today. So the reason why the Office of Professional Regulation, why Sheila Boney's recommendation is to change the language to healthcare practitioner acting within their scope of practice is we do have many different licensed professionals in the state, and scopes of practice really are dependent, particularly in the Office of Professional Regulation, because we regulate some physicians, we regulate the osteopathic physicians, but not the allopathic physicians. There's two types of physicians and they're separated. Physicians have broad scope of practice, but even within them, it would be inappropriate for an OBGYN to do opioid maintenance. So everybody, regardless of where you're licensed, has a scope of practice dependent on their training and expertise. Physicians have it, nurses have it, APRNs have it, which they're a specialized type of nurse, PAs have it. And all of these licensed professionals know what they are trained in and what their scope of practice is. So it's best to really refer to the scope of practice of the licensed individual, because that's what someone is using to decide, should I be acting in this way? So Sheila brought out an LPN. An LPN is a licensed practical nurse. So we have a licensed nursing assistant, a licensed practical nurse, a registered nurse, and then an advanced practice nurse. So 4 different levels of nursing. The 2 at the bottom of that career ladder are not authorized to do the types of assessments that are in this bill. The registered nurse can, and the APRN can. And the registered nurse knows that that is within his or her scope of practice. The LPN knows that it is not within their scope of practice. So it's appropriate to always be referring to scope of practice. The other thing is that when you're talking about opioid maintenance, those prescribers have to take additional training related to continuing education related to opioid prescribing. So if you're an APRN, you may be authorized to prescribe that type of medication, but not if you haven't taken the continuing education. So it's very important to, I think, not get into those level of details in this bill, but instead to rely on the infrastructure that exists in Title III and in Title 26 through the Board of Medical Practice and the Office of Professional Regulation, which really outlines for everybody who's working as a licensed healthcare professional in the Department of Corrections what is expected of them, regardless of setting. And the reason why I'd advocate to you to just put healthcare practitioner acting within their scope of practice is that that doesn't change the framework for people who are in corrections. And from my perspective, from the Office of Professional Regulations perspective, it's really important that the same standard of care is being given regardless of setting. And so if you use the definition that is within the Office of Professional Regulations written testimony, that ensures that the healthcare practitioner is using the same standards of practice that they would use if they were in a private setting or an out of correctional, I don't know the right way to say it, but out of correctional services, but in, in standard medical places. So that would ensure that it was the same, regardless of whether it's traditional medical care like heart medication or ADHD, maintenance medication, or opioid treatment.
So that it really clarifies the statute that the appropriate person is prescribing the appropriate medication within their scope of practice.
Exactly.
And license.
Exactly. And there was a question about whether when somebody is coming into a facility, if there's a new prescription that is given, and it's my understanding that there is, and that the prescriber, in order to continue the medication, the prescriber has to write a new prescription, and then it has to be fulfilled.
Has to write a new prescription just because they're in a new
I don't believe
practitioner with
because new medication is being dispensed.
new medication. So
because-
if it's a continuation of medication that already has an existing prescription, we don't necessarily have to write that again.
My understanding, and I think this is an area that you should get clarification from
Yeah.
DOC because I'm not an expert in their practices, but my understanding is that when someone becomes incarcerated, they tell somebody what their prescriptions are, but they do not bring their medications with them. They have to enter the system without their medications. And in order for new prescriptions to start in the facility, a prescription has to be generated from within the facility after those checks that
Yep.
you really eloquently described, Madam Chair, to ensure that the inmate is telling the accurate truth and that it's a bona fide prescription for a bona fide medical need, right? And then that prescription is done again.
Gotcha. Thank you.
And I believe that there's ways that that's worked out through insurance as well, because sometimes someone has a prescription and then it looks like it's being double filled, but it's not actually.
The other thing too that we grappled with, sometimes a person's coming in with a certain type of medication and DOC doesn't have that medication, so they substitute
Correct.
that. And Isaac, we'd like to have some testimony from your medical providers to really start talking about what the process is for someone coming in who has a prescription and then have that continuity. So if that could be soon, like maybe this afternoon or tomorrow morning. Because we're wide open.
No rush.
We're wide open.
Our medical director right now is also at a conference in Portland about nutrition. So we will try our best. We can connect us to somebody.
We're running up against all the time in setting our schedule with everybody. Just a problem.
Well, not everybody. They're all.
I know, but we keep running into this. That's why we have open gaps in our schedule. Do you want to weigh in, OPR? Do you want to weigh in on anything else?
No, I just wanted to add that clarification, and I'm happy to answer any other questions if folks have a question for either me or Sheila.
Oh, Sheila's gone, yeah.
Oh,
Questions?
May I try one more time? If an individual is detained, they have a current prescription that could be filled if he or she wasn't detained. Does Department of Correction have to prescribe it again, or can they use the existing prescription that's available?
So under the way the law is written on page 7, well, that's related to substance abuse, but it's similar for general medication. The person who is incarcerated has to go through a screening, and they tell the healthcare facility staff what medications they're taking. And then the healthcare facility staff, the healthcare practitioner, verifies that medication is appropriate with the prescriber and with the pharmacy. And then they have to reissue a prescription in order to release the medication from the facility's med stock.
The prescription has to be written, and we want to make sure it is written by the appropriate person who is licensed for that scope of practice.
And if you make that clarification to the definition of healthcare practitioner and clarify that they need to be acting within their scope at all times, that solves all prescribing issues. It solves all healthcare assessment issues. It basically means that they need to always be acting within their scope. And because you folks are not familiar as much with the Office of Professional Regulation, if I may just give a little background. So the Office of Professional Regulation is 43 people. We have a law enforcement division, including 6 certified law enforcement officers. Mike Warren, who is interim director, was most previously our chief investigator for that division. We receive about 600 to 800 complaints a year about unprofessional conduct across all of our professions. Not all of those are healthcare professions. We also license tattooists and accountants and real estate folks, so wide gamut of people. And we prosecute about 100 of those cases a year after investigation. And when we are licensing any profession, we're really looking at 3 main things. Are you qualified? I guess 2 main things. Three. I'm going to go back to 3. are you qualified? Do you know your scope of practice? And then in our enforcement, are you staying within the scope of practice that you have? And are you meeting the standards of treatment? So within Title III, we have an unprofessional conduct statute. It's 3 VSA 129A, and it outlines many, 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 many ways that you can commit unprofessional conduct across all of our professions. And the section that is used the most is failing to adhere to the standard and the prevailing and acceptable standards of practice. And that's exactly what we would do if someone who's working within a healthcare facility operates outside of their scope of practice and fails to provide the appropriate clinical care.
Do you get any complaints within the correctional?
Well, yes, we do. Quite a few.
And have they been substantiated?
I can't tell you that, Madam Chair, off the top of my head. I do believe the answer is yes, and I'm looking at a phone a friend over there. The answer is yes, we have, but the number I don't have.
You know what those claims were about?
Almost all of it was failing to provide acceptable standards of patient care.
And
some of it is also sexual boundaries. We've had that as well. Failing to maintain sexual boundaries with a client.
Within the healthcare part?
That is within a mental
health. While they're incarcerated.
Yes.
So,
because we license all the mental health providers that are also providing care to our incarcerated individuals.
So does that change in terms of the complaints you've had when we've changed a contractor that we provide the mental?
Oh, I don't want to opine on that at this time. We'd have to look at that and figure out when the contractors changed and when our complaints changed.
That would be public information, though, or not.
The number of our complaints and when they came into our office is public information. It would be difficult for us, not impossible, but difficult for us to determine which complaints are related to care within the correctional facility, because that's not something we've segregated out. You know, we look at all of our complaints for nursing together and all of our complaints against licensed mental health counselors together. We would have to look at the descriptions to see if we can determine which ones occurred within a correctional facility, which may be challenging because the way that we describe our complaints we don't always reference that the person is within a correctional facility, because we really strive, and I think this committee does, and I know DOC does too, to provide quality care regardless of the fact that someone is within the correctional facility. So for instance, somebody who is seeing a mental health counselor and that mental health counselor starts to have a sexual relationship with them, and then we receive a complaint about it, we wouldn't necessarily say in our description of the complaint, complainant is an inmate in a correctional facility. We may, but we may not 100%. I couldn't tell you that we wouldn't give you not an incomplete set of data.
But you do get complaints from folks who are incarcerated.
We do.
And then those have been substantiated.
Some of them have, some of them haven't.
Right. But you can't really track that necessarily.
We could probably, with some time, give you an approximate number of folks who were working in a correctional facility and have been found to have committed unprofessional conduct within the last 5 to 10 years. But beyond that would be difficult for us. And with that would take some time, because we would just need to go back. We're very fortunate. Jennifer Colin, who is our general counsel, has been chief prosecutor until a year ago. So she has been responsible for litigating a lot of these cases or overseeing the litigation of a lot of these cases. So I'm fortunate, and I used to be the director of the Office of Professional Regulation. So we're fortunate. We have a lot of institutional knowledge sitting in this room with you on how complaints are received, investigated, and prosecuted when they're received from correctional facilities. And we do receive complaints from people who are incarcerated. We also obviously track media stories. We open complaints ourselves if we don't receive a complaint about conduct that is in the statewide media interest, and we have investigated those cases as well.
So it's the cases that have come from corrections that you've investigated are mostly medical.
Medical, if you're including mental health, yes. So either healthcare or mental health care.
I would sort of like to do a little deeper dive on this and wonder if you could just go back maybe 5 years and see.
We can do our best, Madam Chair.
Complaints came from corrections. I don't want you to go back 10 years.
Thank you.
You know, 5 years brings you to 2020. COVID probably changed a lot of things. I was during COVID.
I don't know that it changed a lot of things in this particular space because the providers were required to be in the facility. The biggest thing that changed with COVID is telehealth and the provision of all of these healthcare and mental health care. And I'm just going to say healthcare and trust that you guys know I'm including mental health. All healthcare delivery changed dramatically with telehealth, but in the correctional facility, that did not change as much.
Right.
How easy or hard would it be if you're about to do this research project that the chair just gave you for the past 5 years to add a field in your database that just asks and answers that question, did this occur in a carceral facility?
Not off the table, but definitely with a development cost and some work. And it couldn't be done retrospectively very easily. But we do have a lot of fields that are checked or used during our screening process, including, you know, is this related to financial mismanagement? Is this related to sexual boundaries? Is this related to, you know, failure to maintain records? We have a lot of screening questions. Whether or not the patient is within a correctional facility is not one of them. And it would come at a computer development cost. I don't know the estimate for that.
Software cost.
Yeah.
I'm sure I'm gonna use the wrong language, but I would imagine if an investigation were opened and it was found valid that the line was crossed, I would think you'd have to know where the line was crossed.
Oh, yes, we know where it's happening. In our investigations, we typically, for these cases, these are big cases for us. We're obtaining all the medical records from the correctional facility. We know where the person was located, but in our software system, that is a different thing. Being able to have it run as a field that's easily mineable is a very different thing. So what I'm saying is, you know, we receive, let's say 200 nursing complaints, and it may say mismanagement of opioid treatment or sexual boundaries violation, because that happens in nursing too. Those are two things, or inadequate patient care, right? Those are, but it wouldn't say necessarily in a correctional facility in our database. So we would have to go into each of our investigations. And that's what I'm saying. Please don't have us do that, because you can imagine 800 complaints a year over the last 5 years, that would be substantial.
Right, but I'm narrowing it down to not the complaints, but where you found the line was crossed. I would think that would be a fairly easy list to get.
That I think we can do.
Yeah.
Yeah.
That should very easily say where the line was crossed.
Yes.
Yes.
Yeah,
I don't,
we are saying yes to, we are saying yes to the request.
Got it.
To give you a list of cases that we have litigated, substantiated.
Right.
Yeah, in the last 5 years.
That term substantiated is really important.
Right.
Except for we don't use that word at OPR. We say a finding of unprofessional conduct, but we understand what you're asking and we can do that.
Isaac.
So I just wanted to remind the committee, and this is a little tangential, but of H 694, which was actually the chair's bill that became law last year, Act 102, which applies to correctional officers, but did raise the bar, amend Title 13 to enhance criminal penalties for sexual exploitation of incarcerated folks in our custody. And that was something that we were very supportive of. Thank the chair, thank the legislature for doing that work last year.
Well, thank you.
Anything else? So we'll schedule some time with DOC Medical to really look at the language and work through that. We'll take your suggested, both Sheila and your suggestion to change the definition of medical, whatever it is, the practitioner. Their practitioner. We also have to work with our legal counsel, legislative counsel. Anything else before we break for lunch and we're on the floor at 1 o'clock? Thank you. Thank you for coming in. We really appreciate it. Thank you for your memo as well. Sheila, thank you.
Thank you.
Sorry.
Okay, folks.